recording it. So then I go to the middle button
Mhm.
here, right? Okay. And then close this. And you guys can still see the screen, right?
Hi,
Yeah.
yeah, I can see it.
Okay, perfect. Okay, let's do this then. Let's see. Okay, is that better? Okay. So this module, I was going to talk about breast cancer surgical management. And I just got this, the topic and the learning objectives from ASBRS. This one, distinguishing indications for lumpectomy versus mastectomy, applying evidence-based margin standards for invasive versus DCIS, and how we make decisions on re-excision. When we think about neoadjuvant therapy, how we incorporate that into surgical planning, and then choosing appropriate axillary surgery with sentinel node or axillary lymph node dissection, and just talking about just a couple of. So this whole thing is going to be less than like 15 minutes or 20 minutes, I think. So, shoot. Let me get this down here. Okay. All right, so let's talk about lumpectomy versus mastectomy. So, as we know, lumpectomy with radiation has the same survival as a mastectomy. The factors that we take into account when we are talking about a lumpectomy versus mastectomy is the breast size, shape, genetics, and if they've had prior radiation. Typically, when they have prior radiation, they need a mastectomy. Really, it depends on the amount of radiation that they have had and how long ago they've had the radiation. That makes a difference. And of course, the patient preferences. And a lot of these things I'm talking about today, you guys know a lot of it. But like Marissa, who's kind of new here, and any people who are not familiar with it a lot, I think they will benefit from this. The main thing that I'm thinking as a surgeon is we want oncologic safety, meaning we want to get good margins, but yet it's also important to me to give them good cosmetic outcomes. So removing the cancer, making sure that they have good cosmetic outcome is important, and of course, depending on what the patients want. This picture just depicts and again, I want to say the pictures are from Google, so I don't want to be accused of copyrighted. It's stealing copyrighted material, so just got them from Google. So lumpectomy, and by the way, this PowerPoint is going to be on the YouTube for others to view in the future, and people who are not able to come on today. So lumpectomy is just removing that area of the cancer. Mastectomy is removing the entire breast, as you know. Okay, and let's talk about indications for lumpectomy. So, unifocal disease with good tumor to breast ratio, achieving negative margins, and delivering the radiation. The contraindications for lumpectomy are typically diffuse multicentric disease, whole breast radiation, persistent positive margins, of course, inflammatory breast cancer. So, typically, we say, like, okay, who is good to get a lumpectomy? Anyone that has, we don't typically go by the size of the tumor. We are usually going with the tumor to breast ratio. Back in the day, there was a size, but depending on how big the breast is, there is never a contraindication for with lumpectomy. If they have a large tumor, but if they're large breast and we can achieve good cosmetic outcome, it's still okay. And for if you're getting a lumpectomy, of course, they need radiation. That's the NSABP06 study that looked at survival benefit. There's no
Is this
survival. Sorry, who was that? Um, did you guys have a question? No. Okay. All right. So mastectomy, of course, patient choice, we know that. If someone has multifocal, multicentric disease and contraindication to radiation, if they are pregnant, they cannot get radiation. So that would be the time we're thinking of mastectomy. If they have extensive DCIS, and if they've had local recurrence after breast conservation, that's typically because they've already had radiation. You can only get certain amount of radiation. Back when, like 10 years ago, when I finished my fellowship, like almost everyone got a mastectomy if they've had lumpectomy with radiation. But anymore, the radiation oncologists are willing to re-radiate the patients, especially if they've had partial breast radiation. And it's been a long time ago. So there's a lot of nuances in that. I recently had a patient who wanted a lumpectomy after having had cancer and radiation. So I said, I'll refer you to radiation oncologist for the shared decision making as to, how safe that was for her to get more radiation. So what are the different types of mastectomies? There's a number of different types. The most common ones that we typically use is a mastectomy that's flat closure, a or a simple or total mastectomy is the same thing where they're completely flat. They can wear bra prosthesis. The other one is skin sparing, where we remove the nipple areolar complex and then the breast tissue. And then there is nipple sparing mastectomy, where we typically make incisions at the bra line and where we spare the nipple. So always describe it as a pillow and a pillowcase to the patients. It makes more sense. When you remove the pillow, you're leaving a pillowcase. In the nipple sparing mastectomy situation, we are leaving the nipple. In the skin sparing, we are removing the nipple and the breast tissue. And there's, of course, the Goldilocks mastectomy. We can spare the nipple or we can remove the nipple. That's more a mastectomy where we remove the breast tissue, but we're using their skin to create a breast mound. Let's talk about margins. Really, for invasive cancer, it's no tumor on ink. So this is the invasive cancer here, and we just want no tumor on ink. So if it's coming to the edge of when we remove the cancer in surgery, in lumpectomy, we are inking it so they get six-sided inks. For those of you guys who are not in the OR, there is, six sides to the mass that we remove in surgery. And so we are inking it. Each ink has a different, side associated with it. Typically, that goes to pathology. They slice it, they look at it. If the cancer is coming to an edge of a tumor, then it's called, there's positive margins. We typically take them back to get negative margins. Back in the day, like over 10 years ago, we used to think we need get wide margins for better survival, but there is this Astro SSO guidelines that have showed no increased survival for like extreme margins. In fact, you take a lot of tumor, your cosmetic outcome won't be as great. So we're basically looking for no tumor on ink for the invasive cancer. The problem is that sometimes the lobular cancers and also DCIS, sometimes it's a lot more extensive than what you're seeing on imaging. And those are the times that we take patients back to get re-excision is when we are looking at DCIS or when you're looking at lobular carcinoma. In neoadjuvant treatments, I'm going to talk about that. I actually have a nice diagram to show you how the responses are for the neoadjuvant and how that determines what type of surgery that they can have. So let's look at DCIS again. If it's just a pure DCIS, which is different than DCIS with invasive cancer, if it's pure DCIS, we want 2 millimeter margins. If there is DCIS with invasive cancer, we typically want negative margins for DCIS and negative margins for invasive. It's very interesting on how it changes. This is all the SSO Astro guidelines is if there is invasive and DCIS, we're basically just want negative margins. But if it's pure DCIS, we're wanting 2 millimeter margins. And I think really reason for that is, as you know, DCIS is inside the ducts. So these are the atypical cells that are growing, and more than half the duct is DCIS. And if it comes outside the duct as invasive, the DCIS is very notorious for skipping the duct. So it could be DCIS here, DCIS here. So if you go and just remove this area, you could have a positive margin. And so you come back and re-excise and you could find more DCIS. Those are the patients that eventually will end up needing a mastectomy if there is an extensive DCIS. And for DCIS patients, they look at the size of the DCIS, the margin size, the grade, all of those things the radiation oncologists are looking at for when they talk about radiation. And when do we re-excise? When there is, positive, any DCIS or invasive cancer, if there's cancer on the margins, you excise it. But if someone is pure DCIS and they have closed margins, meaning like 1 or 2 margins or 1 millimeter, you talk to the radiation oncologist, you look at the patient's, history and their performance status and all those things. And should we take you back? Should we get radiation? If there are more than one, typically we take them back for re-excision. Consider not re-excising when margins meet guidelines thresholds, re-excision, risk poor cosmesis. I mean, there's only so much amount of breast tissue you can take. I definitely think, and the reason I do select all margins, some surgeons do selective margins, there's no right or wrong answer. For me, the reasoning for me is if you're while you're still there, my lumpectomies are pretty small. When I'm excising the tissue around it, your cosmetic outcome is so much better than when you take them back and re-excise it. Also, the other thing is they're taking time off from work, and then, the cost and the pain and the infection. Those are the things that I think of for re-excision is my rationale for taking all margins. And of course, we can present these patients at the tumor board conference. So this slide is actually good. Let's look at it. Neoadjuvant chemotherapy or systemic therapy. When the reason we get neoadjuvant chemotherapy is to downstage the breast and axilla or axilla for someone making them from a big mastectomy to a lumpectomy. It also allows us to assess the response and guide adjuvant therapies. We typically think about neoadjuvant chemotherapy for patients who are triple negative, HER2 positive, if they're lymph node positive. We're also thinking of neoadjuvant chemotherapy for hormone receptor positive patients, especially if they're young and have multiple lymph nodal involvement. If they're needing lymph node dissection, maybe to downstage the disease, they don't respond as much to hormone receptor positive patients, don't respond as much to neoadjuvant chemotherapy, especially the younger women. So if you can do a sentinel lymph node biopsy before neoadjuvant chemotherapy and remove that one or two positive lymph nodes, they don't need a lymph node dissection. But if there is after neoadjuvant chemotherapy, a positive lymph nodes requires a lymph node dissection. When someone gets neoadjuvant chemotherapy, these are the different types of responses that they can get. This here's a complete response. This is concentric, meaning it's like going from the outward in. This is the tumor up here. And then there's fragmented response, as you see here. So sometimes this is really difficult to see on imaging when they have fragmented or Swiss cheese deformity. The area is still pretty big. I mean, you still have to do the same surgery that you would have done before neoadjuvant chemotherapy. And then some tumors don't move; they just sit there and they're stable. They haven't changed. And of course, you also see tumors that progress. And so this is the important point to make. And I have Dr. Santos, who's a resident with me right now. It's important to examine your patients during chemotherapy. And I know medical oncologists do it too, but I think it's important, especially if the patient's tumor is growing during neoadjuvant chemotherapy. That's an indication to stop chemotherapy and take them to surgery. So after neoadjuvant chemotherapy, we reassess them with exam and imaging. And if they have residual disease, um, depending on if they have residual disease in the lymph nodes, the guideline so far is you have to take them back for surgery to do lymph node dissection. And if they have obviously positive margins, you take them back. And then the neoadjuvant chemotherapy really helps us to downstage the disease. But if someone has had cancer in the lymph nodes, the cancer is completely gone on imaging, we can take them and do a targeted lymph node sampling. And then if there is cancer, we bring them back, or we can do it at the same time. So how is the sentinel node done? Again, after they go to sleep, we inject the blue dye and the radioactive tracer into the breast. This is showing around the mass, around the tumor. And studies have shown there's no difference in where you inject around the tumor or around the nipple. This gets traveled through the lymphatic channels into the lymph nodes. So we remove those first couple of draining lymph nodes. So these are the gatekeepers, the sentinel lymph nodes. The cancer has to travel through these lymph nodes if it's going to go to lymph nodes to go to the other lymph nodes. So that is the premise behind doing a sentinel lymph node biopsy. An axillary lymph node dissection is reserved for those patients who have a positive lymph node in spite of neoadjuvant chemotherapy, or if they did not get neoadjuvant chemotherapy, if they have three or more lymph nodes, they always need a lymph node dissection. And if they have bulky disease, they need lymph node dissection. The one thing I want to point out is when we take patients back for lymph node dissection, they've already had a sentinel node in the past. One thing you can do is this thing called reverse lymphatic mapping. And the way that works is you inject blue dye in the arm, and you're injecting into the arm, and basically the blue dye goes and sits in these lymphatic channels. So when you go do the lymph node dissection, basically you're not touching these lymph nodes. You're usually going level 1 and level 2, and level 1 is that right next to the pectoralis minor. Level 2 is right behind the pectoralis minor. So those are the two levels that you're removing, and so that decreases the risk of lymphedema. That's something that you can do to decrease the risk of lymphedema for those patients when we are taking them back for lymph node dissection. And I'll briefly touch on, complications that you guys get called on or see in the office is early complications, hematoma, seroma. So seroma, the way I describe it is, when you remove tissue from the breast or any place, your body just makes that blister fluid. It gets collected, and hematoma, of course, is bleeding that just became now this mass. Typically, hematoma gets reabsorbed. Seroma, depending on if they're symptomatic, if they have redness, pain, that's an indication to aspirate it. But if it's just no problems, they're not having any problems, you can talk about heat, compression, things like that. I think all you guys do a wonderful job in talking to our patients. Wound infection, dehiscence, skin flap necrosis, something that you could see early. Of course, the factors that go along with it is the diabetes, obesity, smoking, and all the other factors. And late complications, lymphedema, of course, when someone gets a lymph node dissection along with radiation, the risk of getting lymphedema is up to 30%. Chronic pain, numbness, neuropathy, we see that. Now, I will say the numbness underneath the arm after a sentinel node lasts a long time. For me, it probably took about 10 years before I started not noticing it as much. And of course, the reconstruction issues, depending on if they have implants or flaps, there are some late complications that can happen, such as capsular contractions and things like that. So, really short talk today. We just talked about breast conservation versus mastectomy. Survival is equivalent as long as the criteria is met. Evidence-based margins, no tumor running for invasive, wider for DCIS. For neoadjuvant versus modern axillary surgery strategies to reduce morbidity. So we're doing more and more to de-escalate surgery. Doing less and giving people the same amount of survival. And then we talked about, helping when they have complications. So it's a pretty small talk. I'm going to go back in here to stop recording. Okay. Let's see. Wait, did I get out? Do you guys still see me? Okay.
Yeah, I can still see.
Okay. Do you guys have any questions?
I do have a question.
Yes.
So, when they use